Yeah, we core it, aren't we?
Oh, we definitely core it, yes. We've just got a couple more people to come. But we've got Kerry here for the patient story, the first item.
Right. Well, let's get started then. So, welcome everyone. Welcome especially to Juliet Armstrong from Southwest London and St George's, who's observing. Thank you very much. And we have two of our governors observing too, which is fine. So, any apologies?
None received.
Okay. Declarations of any other business? Declarations of interest? Minutes of the meeting of the 13th of September. Any corrections, please? No? Okay. The action log, the matters arising, I think they're all either done or in hand at the moment. Okay. So let's move on then to the patient story, item 6, physical health monitoring for patients with serious mental illness. Debbie, are you going to say a few words? Debbie here?
Sorry, Debbie's got problems getting in, so
Okay.
I'll invite her.
Kerry, are you going to top and tail this, are you?
Yeah, let's go to invite Kerry then to kick off. Over to you, Kerry. Welcome.
Oh, thank you very much, and good morning, everybody. I will just endeavour to share my screen.
That's fine, thank you.
So thank you. So thank you for inviting me this morning. I'm Kerry Harrison, the Senior Physical Health Lead here at Berkshire Healthcare, and I'm responsible for the service we offer, providing physical health checks for people with serious mental illness in the community. And I'm going to share the story of Luke to highlight what the service has done and how it's evolved over the last sort of 18 months, 2 years. So just to kick off really, why are physical health checks so important for people with serious mental illness? We know someone with a serious mental illness is likely to die 17 to 20 years younger than the rest of us. But these are of diseases like, that everybody gets: cardiovascular disease, diabetes, cancers, and these are often preventable or treatable. And the reason we see this so much in people with serious mental illness is there's a number of additional risk factors in this group of patients. We're likely to see much higher alcohol consumption. They're 3 times more likely to smoke. If we think that a third of all cigarettes smoked are smoked by people with some degree of mental difficulty, and that in a mental health inpatients unit like Prospect Park, about 50% of the people smoke. And there's double the risk of obesity and diabetes, mainly due to the medication that we give people and also the sort of lifestyle issues. 3 times higher risk of having high blood pressure and 5 times a higher risk of having problems with cholesterol and blood fats. So prior to 2021, to access a physical health check in Berkshire, patients were identified through the care programme approach, which is a programme that people with complex mental health issues are under. But by pulling patients this way, we were missing some of the patients that had got a serious mental illness if they maybe hadn't got the right diagnostic code, or there were some people on a care programme approach who didn't meet the criteria for a serious mental illness. So it was a bit of a flawed approach. The checks were mainly accessed through GP. We've got a very limited secondary care offer in the community. There was a real lack of parity between physical and mental health, and also a lack of awareness across our mental health practitioners and also our patients as to how important physical health is, and that huge health inequality that this poses. And at this point, the trust compliance was only at 14%. So we're over 80% of our patients weren't getting that physical health check. And in secondary care, we're responsible to do that health check for people who are in the first year of their serious mental illness, or if they've come back into services in the last year. So, it was quite shocking that over 80% of our patients weren't getting this health check. So since January 2021, we now have a physical health team based in Berkshire Healthcare. We've got a really reliable data system. We pull patients, we identify them by their diagnostic code, so we know they've got a serious mental illness. We offer clinics in 7 locations across the county, in all the main towns, as well as a community-based clinic in the Oxford Road in Reading. And we also obviously do home visits. The team are really tenacious in their attempts to engage with people, and that seems to be making a huge difference. And we've also rolled out a programme, both online and face-to-face training for all our mental health staff. And this really is focusing on raising awareness and how important it is for people to have these checks. So I'll move on to Luke. Obviously, I've changed his name. He's 35. He's got a diagnosis of paranoid schizophrenia about 11 years ago. He's an ex-drug user. He has his veins are absolutely shot to bits from a real sort of career of intravenous drug use, although he doesn't do that anymore. He has a very sort of limited life in that he spends most of his time at home. He's unable to work because of his mental illness, but he does do all his own housework and his cooking and his shopping. He's got really good support from one of his parents and one of his siblings, and he enjoys the sort of online interactions that he gets through computer games. He smokes, which is a huge risk factor, and we picked up that he'd last had a health check over 10 years ago, really when he was first diagnosed. And we picked him up in 2021 because he'd actually come back into services because he'd had a bit of a relapse. So when we first saw Luke, as I say, he was identified through our new system on Tableau, our reporting system. So we booked him in for a physical health check. He refused to have any attempts to have blood taken. He's had such bad experience of people trying to get blood out of his dreadful veins. There was no way he was going to allow us to check his blood fats or HbA1c, which is the check we do for diabetes. He was a bit overweight. So ideal BMI is under 25, over 30 is obese, but between 25 and 29, that's the danger zone of being overweight. But his other physical health parameters were normal, so he was given some advice around how he could perhaps improve his what he ate and his cooking, and we also gave some activity advice. We always talk about activity rather than exercise. If people do nothing and sit in their chair all day, to then talk to them about taking exercise can be really off-putting. So we tend to talk about activity and things people can do around the home, like, you know, taking a walk around the sitting room in advert breaks or doing a little dance while you boil the kettle, just to get people moving a little bit more. He wouldn't have any discussion at all about smoking, didn't want to know about that at all. And then we referred him on to his GP for his ongoing annual physical health checks, because that's kind of the shared care agreement that we have. Then in 2022, we were able, through some support with NHS England, to bring into our clinics some point of care blood testing. So we could do finger prick testing in the home to get instant results for blood fats and diabetes screen. So just a little prick of the finger rather than the full venous sample. And my colleague who'd seen Luke the previous year remembered him and thought, well, he's having these checks done at the GP, but he won't have had a blood test done. Let's bring him in and offer him this machine. But when we checked on Connected Care, we could see that he actually hadn't gone to his GP. He wouldn't engage. So we thought, okay, let's get him in, do the bloods through with our new machine, and do all his health checks, because he hasn't had anything done this year. So real tenacious approach. He was really hard to get hold of, but we managed to get hold of him in the end, and he agreed for a home visit, and he would have the bloods done through finger prick and his full physical health check. So Luke doesn't like to get up early. He likes to have a nice warm drink, a nice lie in. So he didn't want to be seen before 11 o'clock. So we arranged to see him at 11 o'clock. He found his BMI had actually improved. He was still a little bit overweight, but he had taken on board the eating advice that had been given, which was great to see. Good blood pressure, which was really healthy. And then we were able to do the point of care blood test, as we call it. So you get the results 7 minutes after you've done the finger prick, which then allows you to discuss those results in the same appointment. He'd got a healthy range for diabetes screening. HbA1c needs to be under 42, ideally, but his blood cholesterol was high. That was able to be picked up, which obviously we hadn't been able to pick up before. Didn't want to, again, think about stopping smoking, but actually this time he did say he'd quite like to have a discussion about it. So the things we did to try and reduce his risks and improve his health, really praised him for his weight loss. A 5% weight loss and maintained is considered a success. So he was praised for this, and just a bit of a chat how he could really keep going with that. Referred to his GP regarding the blood cholesterol, but obviously mindful he was unlikely to consent to go and have full fasting lipid profile, but at least we knew we could give him some advice around his cholesterol to try and start to address that and reduce his risk of having a heart attack. We were able to talk to him about what local stop smoking services can offer. So there's a 12-week support, free NRT. We also talked to him about e-cigarettes. As nice guidance now is that e-cigarettes, vaping is a really useful tool to help people cut down. They have to buy their own, but they're cheaper than cigarettes. So we talked to him about having maybe a cigarette and then the next time having a vape, and a cigarette and the next time having a vape, just to try and reduce that amount of tobacco. And we talked to him, as I said before, about moving more and getting active, because we know that sort of all elements of physical and mental health are improved by getting a little bit more active. We then provided him with some resources. So we have fantastic access, Better Health, Let's Do This NHS app, really good weight management and recipes on there that are, what I'd like to say, is normal foods that are not expensive. So they're not fancy, expensive vegetables or really high quality, fancy meats and things. It's, you know, recipes using carrots and cabbage and things that we can buy sort of fairly cheaply. So we gave him that resource, which he was really pleased to receive. We gave him the links to Smoke Free Berkshire because people can refer themselves to that. So we've sowed the seeds, and then we've given him something that if he wants to take that forward in the future. We gave him a book from the British Heart Foundation, which talks about cholesterol, and it also has a link to a really nice video in there that patients can watch and get a bit more information. And then finally, although Luke never left the house, we did give him a timetable for Sport in Mind, the charity we have across Berkshire that has physical activities for people who've got mental health difficulties, which we hope maybe would sow the seed that he might want to come out and start to get do a little bit more. So just in summary, Luke hadn't had a health check for 10 years, and the team was able to give him that full health check and those really important interventions that help reduce his cardiovascular risk and hopefully will stop him dying younger than his peers. So it really did sort of address those specific risks that he was facing. So particularly with Luke, a little bit overweight, but his cholesterol and his lack of movement. And he really engaged well with the health check. He had good humour and he was really thankful for what we offered. And just finally to say that the trust compliance for health checks now has gone up to 80%, and we've set ourselves an aspirational target to trying to get to 95% by the end of this financial year. So thank you very much everybody for your time. I will just unshare and open up for any questions.
Kerry, thank you very much. A very clear and interesting presentation. Could I just ask a couple of questions just before we throw it up? In terms of serious mental illness, what is there a sort of clear definition of that? And is it is it sort of at a very severe level, or is it?
Yeah, it's more the type of illness where it's the psychotic type illnesses, so schizophrenia type illnesses. It's any mental illness where the patient is required to take antipsychotic medication, because we know that antipsychotic medication, although really good, it does cause significant side effects in terms of increasing cardiovascular disease, liver problems and weight gain. So there is a specific set of diagnostic codes where people fall under that criteria.
Kerry, thanks so much. Julian.
Sorry to get myself off on mute. Thanks, Martin. Thanks, Kerry. Great presentation. We have certainly made great strides, haven't we? And I think it will make a big difference in terms of people's well, quality of life, really, and addressing those health inequalities. So thank you to you and your team. The issue that I was thinking about was that effectively we're doing this, you know, and getting everybody, but the next phase presumably is to get the same service that I can get from my GP, so that health checks happen in primary care as well, isn't it? Because otherwise you're going to end up with all the new referrals coming in, plus having to catch up with all the people on the existing caseload, which will just swamp us. But also, we'll send a message around mental health somehow siloed over here, and you can't access primary care. So I get the rationale of seeing the new people, making sure they're done and but how do we make sure that on an ongoing basis people can access primary care in the way that Martin and I can?
Yes, so we do work really closely with primary care, and the shared care agreement is that in that first year, as I said, we do the checks, and then they go out to primary care to have those ongoing checks. And there are various sort of incentives and QOF, I think, out in primary care, and they've got their own targets to achieve this. So they do work very closely with us. But what we have noticed sometimes it's our patients struggle to access the check in primary care because of their severe mental illness. So they may still be under our care, but the check should be done in primary care. So we are starting to look at the data around those patients that are still under BHFT, but are more than a year, and to see whether they are having their health check. And we're really working closely with our care coordinators to say, you know, they had their health check with us in the first year, you need to get them out in front of the with their GP now and get them booked in to have that health check done. But I think it is a challenge. We have a very flexible approach. We are, you know, sometimes we can have 5 or 6 interactions with the patients before we get them in front of us, whereas unfortunately, due to the pressures out in primary care, they might get a text message or a letter asking them to book, and they won't necessarily go ahead and book. But now we can see that, we can liaise with our care coordinators and actually say, look, can you really work with that cohort of patients and get them booked into their GP? But it is a bit of a challenge to, you know, because of the amount of the amount of time we can spend to get one health check done just would not happen in primary care.
Thank you. It's a question which I was going to ask as well, related about just the compliance going down, because I certainly recognise the issue of, you know, someone getting a text message from their GP and then just ignoring it, particularly if you've got some sort of stress in your life from mental illness. You know, it's one other thing you just don't want to get involved with. So is there a proper model for the longer term? Because you recognise the pressures on primary care, but I'm not quite sure I understand what the solution is. Is there for the longer term, not just the, you know, the first intervention? Is there something, or is that yet to be really worked out?
So we do have data sharing with primary care, and annually we send them what we call the SMI register, the Serious Mental Illness Register. So that goes out to primary care, and then they can identify their patients that way to see that they've had their annual health check done.
Yeah, okay.
In terms of the training we do with our care coordinators, if the patients are over a year, you know, that since they've had their health check, we can very simply still go into our Tableau system and see whether those health checks have been done, and then we can flag to our care coordinators that you need to actually try and get this patient to go to see their GP. They're big numbers out in primary care.
I can imagine. Any other questions for Kerry, please? Sally.
Yeah. Kerry, a really interesting presentation, and I have to say, I've not seen a model like this, you know, where you have a separate group of people who are doing the physical health checks. So part of my questions have already been asked by Julian and Martin. I just wondered, in terms of, often they're done, aren't they, by people with serious mental illness who are often going to depot clinics, they have care coordinators, admissions. I just wondered, in terms of part of it will be encouraging the GPs to do these, and I could wax lyrically about that, because I think it'll be about making sure they get paid for it, that sort of thing. But the other part surely would also strengthening those skills in our own staff, because what you want, what the trust can offer, is integrated mental and physical health care, and what we're doing here is sort of disaggregating it in a sense, although it's had fantastic impact on our compliance rates.
Yes, so up until prior to 2021, our model was that we were trying to train our care coordinators to undertake these checks, and we tried and we tried and we tried, and it wasn't working.
Right.
So we were then we adopted a new model where we have a physical health. So I've got a really small team of 2 nurses, 1 East and West, and healthcare assistant East and West, but they are embedded in the community mental health teams. And since we adopted that model, that's when we'd be able to get our compliance going. But what we try to do is whenever we book a patient in is that the care coordinator comes with them. So it's an opportunity to really change attitudes around physical and mental health. And we've now just gone live with training, and it's physical health awareness training. So rather than training all our care coordinators to do the checks, it's actually, we want them to be aware, we want them to book their patient into our clinic and come with them, and we want them to follow up on some of the advice and interventions around smoking. So it's kind of, we've combined it like that, but it's definitely, we are very integrated within the community mental health teams.
Well, that's it's good
And
to hear that.
It's
good to hear that. Thank you very much.
Thank you.
Anything else for Kerry? Kerry, thank you very much. Very clear presentation and a very interesting topic. And I think it'd be interesting to see how things evolved in a more joined up world with primary, in the longer term. But thank you and your staff for all you're doing. It's great. Thank you very much.
Thanks for allowing me to come to speak to you. Thank you very much.
No, it's a pleasure.
Bye-bye.
Martin,
Sorry.
I should have mentioned, Martin, that I had an apology from Tamina. Tamina is unwell today. She's got sore throat and stuff. So I should have said that at the beginning, but you were a bit quick. So I've got it now.
Sorry. Okay, thanks. Sally, did you have another point? You're on mute.
I'm trying desperately to lower my hand, but
don't worry.
The technology.
Don't worry, I'll do it for you.
Brilliant, thank you.
Okay, well, thanks so much then, Kerry. We'll let you go. That's great. Right, if we could move on to the 6.1 Health and Wellbeing Update Report. Steph Mokes is here, I hope. Are you here? Yeah.
Hi, Martin.
Hi, Steph. We've got the report. I think it would be helpful, to me anyway, if you could sort of paint a little picture, as it were, of the overall health and wellbeing offer, because we're obviously doing some great stuff, but it'd be useful just to sort of paint the overall picture. Would you better do that?
Yeah, certainly. In fact, I've got a presentation that I do at induction, which I could
that's fine.
take you through if that works.
Yeah.
Because that outlines all of our, or at least the high level of our
just the high level stuff. Yeah.
Yeah. 1 second, and I will get that out. So while this is loading, I'll just introduce myself. So I'm Steph Mokes. I'm the Health, Wellbeing and Staff Engagement Lead. So Jane's asked me to present this today. She's not available. Just share this. Very timely, as I did this on trust induction yesterday, so I should know it. Okay. So there's a lot of health and wellbeing support that we now provide at the trust. It's a bit of an information overload sometimes when we take people through it. I think the main thing that I always like to say is we have 2 aims within our team. So one is to develop that organisational wide health and wellbeing support. So stuff that's going to either help everybody or help a particular group that needs support. But then the other part of our role, which I would argue is the harder bit, is to enable staff and teams to look after their own health and wellbeing at work, because what works for my wellbeing isn't going to work for you. What works for my team may not work for another team. So it's about enabling individuals to look after their own wellbeing at work. I'm just going to skip past this bit. So lots of mental health related support, and I have to generally encompass it in groups, but it's not that easy. 2 of the big ones that we've got are Health Assured and Wellbeing Matters. So Health Assured are our employee assistance programme, which is a 24/7 helpline available to all staff. They can phone for in the moment support. They can get legal, financial information and guidance. They can also access the My Healthy Advantage app, which gives them access to things like 4-week programmes to, start exercising, stop smoking, all of those sort of things, leaderboards, breathing exercises, all available through that app. So it's a really big, wide offer. The other side of it is Wellbeing Matters, which is our staff mental health and wellbeing hub, which is run by Berkshire Healthcare, but for all health and social care staff within Berkshire. And they can also provide that in the moment support, but then access to mental health services and rapid assessments into things like IAPT or secondary mental health care where needed. So they provide a bit of a different offer. So they might point someone onto Health Assured, for example, or they might point onto IAPT, or they may just be able to do some interventions themselves, like support for post-incident, shape coaching for trauma. So there's a different, they're complementary, but they are different offers there. We do have our staff support post-incident service as well. So if there's a team or an individual that's been through an incident at work, we can support them. Some of that's raised through Datex, others is just either the individual or the manager flagging. There's lots of access to free wellbeing apps, and this is sort of national offers. One is the Silver Cloud. So we've got a particular Silver Cloud for staff now. And we also run mental health first aid. We've actually just moved that to Wellbeing Matters. So Wellbeing Matters now provide that, but it's the same offer as we had before. And then we look at, rather than, because we've got so much other good mental health support, it's not that someone would go and find a mental health first aider in the trust. They would have a mental health first aider within their team that would feel more empowered to have those conversations. We've then got lots of physical health support, so ergonomics, doing desk assessments, really important, where we've got a lot of people working from home now, but also those working at desks anyway. We provide vouchers for eye tests. We've got the early intervention physio support, so all of that. If you've got a back issue or whatever it is and it's impacting on you at work, you can access that physio support firsthand. Rather than waiting the NHS wait times. The really big one that's worked really well over the last year is the PEPI app for menopause support. So we've just gone to unlimited licenses for that. So all of our staff, however many of our staff, can access that over the next year. And that's really positive because it's not just for the staff members, it's also for their partners as well. So it doesn't have to just be half of our workforce, it could be everybody. I put the fitness platform on there, but actually I noticed this yesterday, but I wasn't expecting to need to do it so quickly. I put the fitness platform on there, but actually we've just brought in our own fitness instructor into the organisation. So Michelle's going to be doing yoga, Pilates, boxercise for staff, sort of before work, after work, at lunchtimes, virtual sessions, and then looking to work with teams to run face-to-face sessions as well. And then she'll be looking to bring on other trainers in other sessions or different times, or things like nutrition, mindfulness, etc. And then there's lots of support at work. So things like wellbeing champions is a really big thing for us at the moment. So we're trying to improve our communication with our frontline staff that don't access emails, don't access Nexus. So wellbeing champions is really big on that. And although I haven't put this here, something else that we've started this year is we've created a wellbeing at work newsletter, which is a physical newsletter, and then that comes out 3 times a year, and we go and distribute that round to our sites and have conversations with our staff while we're there about what's working, what are we missing. So we're doing a lot of work around that as well. And then finally is the financial support, which I know you can imagine is a big area for us at the moment. So a lot of that's about signposting people to things like Money Helper that run an NHS support. So they do a specific support for NHS staff. Some of it's about pointing people to discounts like FivUp, like Blue Light Card, which I think we were just in discussions about whether or not we can offer that through the trust as well. We've linked now with food banks. I know that sounds like a negative thing, but actually I'd much prefer that staff, that if they're in crisis, they can come to us and get access to the food banks quickly, rather than having to try and get a GP's appointment or try and get through to Citizens Advice Bureau. And then we can look at what other support they need there. And then we're looking, I guess, more future for this, and looking at things like WageStream, which is a an offer to get a salary advance. We're exploring whether or not we can bring that in, because actually a lot of the times that people struggle is that last week before payday. So whether or not we can bring some more flexible ownership in around their own pay and being able to access that at times that suit them. So that's a bit of a whistle-stop tour, but hopefully it gives you a good overview of just some of the health and wellbeing that supports that's available for staff. Does that work, Martin?
That's perfect, absolutely perfect. If you can unshare your screen. Oh, you've done it already. Quicker than I am. I think some fantastic stuff going on here, and you know the trust is being recognised for this, which is great. We've got lots of questions. So Mahmouda, and then Aileen. Well, then Mark.
Thank you very much. Thanks very much. Thank you very much for that presentation, and it's really encouraging to see the wellbeing support mechanisms and procedures within the trust, which is really heartening. I just wanted to know if there's any record or any indication of how many of the staff are actually using these schemes. Obviously, I appreciate it's confidential, but I just wondered, was there any way in which we could find out how helpful and useful these schemes are, and whether there can be any sort of tweaks to make it more useful or accessible?
Yeah, so actually that's a big focus of mine at the moment, and actually was talking to Mark about this last week or the week before. So we do get usage reports for quite a lot of them, but not all of them. So for example, one that I didn't actually mention was we've just launched access to HSBC financial education sessions, but because that's a public platform, we can't see how many people are accessing it. So that sort of stuff we might not do, but things like our EAP, you know, food banks, those sort of things we do. So it's a bit hit and miss depending on if we can get usage. And then the evaluation from it, again, kind of depends on whether or not we know if people are accessing it. It's a really big area within health and wellbeing of how do we prove that these things are having an impact? How do we prove that it's delivering that return on investment? And it's a big focus. So it's something that I'm looking at the moment about how do we do this on a more regular basis and figure out what needs to change and what needs to tweak, or what's working well. We just need to improve the access to it.
Okay, thank you so much, and good luck with that, because I know it's quite a big task you've got ahead. So thank you.
Thank you, Mahmouda. Mark.
Thank you, and thanks for the presentation, Steph. A couple of points that I wanted to make. First of all, as our wellbeing champion from the board, I've been having regular monthly meetings with Steph over the past year. And what she has contained in her report and summarised this morning in her presentation really is only the tip of the iceberg. And there is an enormous amount of health and wellbeing initiatives that she and the team have managed to weave through all of the trust's activities and day-to-day services, and they've done it in a really sophisticated and effective way. And I just wanted to, I don't mind sparing her blushes, but I think that her and the team have achieved a tremendous amount that if you dig beneath the surface, you'll find. That's the internal part. The external part is that I'm also a member of NHS England's Health and Wellbeing Champions, where we meet, and indeed there's a meeting at 2 o'clock this afternoon, on a regular basis with other champions and share our experiences and learn more about what is happening across other trusts. And I can genuinely say that we should hold our heads up with pride in terms of the extent to which we have embedded health and well-being across the trust in all different ways and shapes and forms, really is at the top in terms of the discussions that take place at those forums. So I just again wanted to assure my board colleagues in terms of the quality of what is being done and the extent to which it's being embedded across the trust really stands up so well across all of NHS England's participants in that group. So thank you, Steph, and the rest of the team.
Mark, thank you, and I'm sure we echo your congratulations to the team. Naomi.
Thank you, Martin. Thank you, Steph. And actually, Mark, you answered one of my lines of inquiry around how does this sort of stack up. I mean, my reflections on this, Steph, is if I look at this through the lens of a commercial organisation, and I would say it's in the Premier League. You know, if I would just love to see an organisation of our sort of scale, reach in the commercial arena doing as much as we see here. So I think for us, the challenge going forward, and I'd appreciate a commentary on this, is how do we make it sustainable at such a high standard of delivery? And in part, I think, you know, you've already pointed to it, which is it's about trying to measure the value that is delivered and the uptake and so on and so forth, because with that data and information, you can tweak it. But any insights from your good self about how we maintain this going forward?
Yeah, it is really interesting. Alex actually just put in the score that I was going to mention. So yeah, we are doing really well nationally on this. So our staff survey feedback, you know, we was 74.5%. So we were within 1% of the top people saying that the trust takes positive action on health and wellbeing. So it's definitely stacking up against others. I think going forward and how we make it sustainable is to continue growing in areas where there's, you know, focus coming out. So we make sure that the basics are there, and we make sure that we're getting into our frontline staff, and we're making sure everyone knows about it, because I'm very conscious that we've got this amazing offer there, but I bet if you go and speak to nurse blogs on the front line, they wouldn't know about half of it. So that's a really key point for me, is actually making sure it's accessible to everybody, everybody knows about it. I think then the other part is then responding to need as it comes up. So obviously menopause has been really big recently, and we've done a lot around that. We just launched the menopause policy. Financial is coming up at the moment, but we don't know what's going to be the next thing that comes up. So it's going to be about responding to the situations as they come up, and making sure that our offer is always relevant and it is meeting the needs of the staff as they grow and as they come up.
Great. Thank you. To be encouraged.
Thank you, Naomi. Julian.
Thanks, Martin. Many of the points I was going to make have already been raised, so I'll keep it short. It was mainly around the evaluation, really, about, you know, what works and how we might get something a little bit more specific than the staff survey response, which is very encouraging about a general approach that we've got, rather than the specificity about, you know, the PEPI apps, you know, really done this or that. But the other point I would make, and I think is really important for us as a board, is obviously to try, particularly in mental health and stress and everything else, to try and do everything so that people don't need the support in the first place. So some of the things that we know we lost our shape on during the pandemic sound very simple, but actually, you know, great one-to-one supervision, great appraisal, compassionate managers running great team meetings, you know, can be a source of actually eliminating stress, anxiety and tension at source. And that's one of the things, you know, that I'm trying to focus back on now post-pandemic, that we get those basics but fundamentals right, so that actually, well, you've all done it when you've been to a team and you think, wow, this team can sort most things out, and you've been to others where you're thinking, gosh, you know, I'm not quite sure I'd want to have a problem and raise it in this sort of team, really. So there's that bit as well that we've got to do. So it's nice having these schemes, but some of this has got to be about us using some of the fundamentals to prevent some of this happening, and I think that's got to be a really powerful focus over the next 12 months for us, I would say, and something certainly, you know, Alex and Jane are thinking about, particularly as you know, we train up new managers. What does that look like, so they're equipped around that?
Julian, I think it's an excellent point you make, because we do want to have this embedded, don't we? We don't want to have to sort of add things on. And I think it might be interesting to think about the skills we need generally for our managers, if they need, you know, more of the sort of people skills than perhaps traditionally we've given them emphasis on. But Steph, look, this is fantastic work you and your colleagues are doing. So sincere thanks to you and everyone. And, you know, we're in some difficult times for staff, financial, work pressures, etc. So I think this is just spot on in terms of what we need to do. So thank you very much.
No problem. Thank you for having me.
That's a pleasure, and we'll let you go.
Thank you.
Thank you, Steph. Okay, well, that's great. 6.2 Patient Experience Quarterly Report. Debbie.
Sorry, I couldn't. Struggling to join this morning for some reason, so sorry about that. Yeah, this is our usual quarterly report. nothing kind of unusual in it, I would say. What I would say is it's brilliant to see that we've actually virtually doubled our patient feedback through the I Want Great Care score this quarter on last quarter. So I think we're starting to really get some meaningful data around that is really usable for services. We have got some services that are still using it less than I would like, and children's services are actually looking with the young people and their parents about how they might promote this better to actually start really seeing some traction on using that. But in the main, the themes that were coming through, overwhelmingly positive in terms of staff, and issues around CAMHS wait time still being one of the most consistent themes, I would say, across our services, which is probably no surprise to anyone here. And that's probably all I wanted to say, and I'm happy to take any questions.
Thanks. Deb, just before I throw it over, oh, Mark. I won't ask a question, Mark, and then Sally.
Sorry. Yeah, Debbie, I just wanted to highlight on page 57 where the use of feedback is being used in terms of changes and improvements. I found that section really powerful in terms of it's all very well for an organisation to seek feedback and to receive that, but then people are often left wondering, well, what happened to it? And those tangible examples that we used in the report, I found really illuminating in terms of what is being done with it. Whether that could be continued into the future just to give us reassurance in terms of what is happening would be really welcome.
That's certainly my aim, Mark, and that's the beauty of the I Want Great Care tool, which lots of patients are providing good stuff and really positive stuff, but also, even if they're scoring highly, some suggestions for improvement. So we're really working with the services now, and if you walk around and do your visits, you'll start to see that a number of the services are actually displaying this. So you can go into physio and see they're displaying what they're doing. You can go onto some of the wards. So that's the next stage, really, the so what, and it will continue to be in this report.
Very good, thank you, Sally.
Debbie, fantastic report. I mean, really, really comprehensive. I don't think I've seen a patient experience report quite so comprehensive, and it's great to see that, you know, I Want Great Care, the response rate going up there. I just wanted, when I looked at the formal complaints, I just want some assurance around how we look at them and whether there's anything more systemic. And I was looking particularly, but perhaps it's just where my antennae gets alerted. Very few children are transitioned from CAMHS to adult services. And those, so it's a small number, a very small number we're talking about, but it's a very, very, as you know, very, very critical time. You sometimes get incidents of self-harm if it's not. And yet we've got a complaint there around poor transition of care. And I'm just, it just alerted me to, when we get these complaints, whether we think, is this, there's this one complaint, but is there something here around transition? And I suppose I'm asking that because I know transition is a difficult time. And it's something that lots of trusts find challenging.
Julian's just put his hand up, so before I answer, I'll let him come in.
Well, certainly, I have an opportunity because I sign off every sort of complaint, and I will often send something back for further work. Obviously, for obvious reasons, I don't think it's answered the question, or I don't think it's set out in the right way. The second reason why I'll send it back is if I think, oh my gosh, the process we've got here it's not about this individual complaint. You know, this could happen to anyone. It's just so yes, we do send that back to a service. So a good one is that I've sent back recently wasn't a CAMHS one, but it was one where somebody was referred into multiple adult services because they weren't sure, and they were literally ping-ponging sort of about, and I asked for a review of that and a review of how the services in that particular locality could reorganize themselves, and then commit in writing that would change as a consequence rather than just resolving that. So certainly there's that opportunity where we do spot a systemic issue for us actually to push it back and actually ask for the systemic review rather than the individual review. Debbie, you were going to say something more, I think.
Yeah, I mean, that probably covers off. So yes, that's certainly one element of it. We do have a group that looks at all complaints, concerns, incidents of serious nature that come in. which have numbers of our leads from infection control, safeguarding, complaints, incidents, patient safety team, so we can look at that. And all of the divisions have a patient safety and quality meeting, which also looks at triangulating that, and then we are able to aggregate that up to actually share learning across the organisation as well. So certainly, in terms of process, all complaints are signed off by a clinical director at divisional level, and then they go up to Julian, sometimes to myself, if Julian's not around, or Alex. So they do get quite a lot of scrutiny from a mortality perspective. We see the complaints that come in around deaths as well into our trust mortality group. So there's a fair bit of oversight of the complaints.
And we get put that lens on it. Thank you.
Julian, did you still have your hand up?
Yes, just very quickly, Martin, just to say, Debbie, how do we get, so just a couple of things, how do we get really good information really quickly to teams and individuals from this? I think I saw a bid from Ian Haywood, is that right, to get some more software to be able to extract the information more easily? So if we think about what we're trying to create as a board, we've had a conversation about us really trying to create excellence for patients in terms of experience and a culture that reflects that. And I suppose the I Want Great Care is great, but it's what we do with it, how we share it, and how we make it easy for people to see what's been said about their service and their practice, really.
So it's available 24/7. At the moment on Tableau for all services to be able to see, and it's got there's a live feed daily from I Want Great Care, so it's something that's put in today will be able to be seen tomorrow. So it's pretty quick, and I do know that services are sharing. So although I don't see names of individuals when they are giving compliments necessarily at a high level, at service level, they can absolutely see where people are named, and I know they are providing that feedback to individuals, and so they're using it in a positive way as well as looking at from an improvement perspective.
Okay. Sally, is your hand a legacy hand? Okay, don't worry. Alex.
Debbie, really rich data in I Want Great Care. And I was just thinking towards the future and the personalisation agenda. Could you see a future state where we're connecting up individual patient feedback to their patient record so the clinician can understand history of experience and needs from a feedback perspective for the individual in front of them? Because our feedback is generic, isn't it? It's not linked to individual patients. But when we're thinking about the future, personalisation and linking this rich data set could be a route we might want to go down. It's
anonymous at the moment, Alex. So I guess it's whether, we'd have to give some thought to that about what patients' feeling of it as well. So
but just in terms of that principle of really understanding the holistic needs of the patient and connecting clinicians to that feedback directly might be helpful in the future. Who knows when, but just it's where you could go with this kind of information.
Okay, Naomi.
Yeah, thanks, Debbie. It's great to see a relatively new tool coming to fruition. So I reflect on the hard work and endeavours that were put in order to make it happen. So it's really good to see. I have a couple of things on my mind. One is, whilst the uptake in terms of response rates is climbing in the way that we would want, how satisfied are you that momentum is going to continue? Because I can see, and this is speaking from experience, that the tool may plateau at a certain moment in time, and then an additional push would be required to kick that on. So just and it might be just, rather than a very specific scientific kind of response, just your gut feel about where that's headed and whether or not there are any thoughts about intervention if it does start to plateau. The other question is more specific around CAMHS. And if I sound like a bit of a broken record, forgive me, but I can't help drifting towards the words that we have in the paper. It's actually on page 41, 42, where we see wait times for CAMHS featuring yet again across both formal and informal complaints, local resolution and MP inquiries. If I'm brutally honest, I feel like that wording is getting a bit old. You know, it seems to sort of come around time and time again. And whilst I don't want to sound grumpy about it, at a certain moment in time, because of who we are and what we do and how good we are at it, and I appreciate this is at system level, you know, the difficulty resides there. We should have a plan to influence that. So those are the two things that are on my mind. Your thoughts?
So from a plateauing perspective, the feedback we're getting pretty unanimously is the services that are using the tool really well are really finding benefit from it, are really, you know, I don't think they'll go backwards. I think the challenge we have at the moment, which is what we're working on, is those services that haven't realised the benefits in quite the same way at the moment, and therefore we want to be encouraging more use. The other thing is, even if a service, and we've seen this in a couple of services, talking therapies would be a good one, even if services originally didn't think that it would be of value, because one of the ways that we get feedback is through SMS text message to offer. So in that quarter, I think we had 470 odd talking therapies responses because people came direct, even though it wasn't necessarily being heavily promoted by the service. So actually some of this is in the power of the patient, so to speak, in terms of wanting to provide that feedback. So I'm not worried about things slipping back from the services. It's the ongoing supporting more and more and more services to see the value of it. In terms of neurodiversity and CAMHS, someone else might come in a minute, but in summary, we have got somebody in at the moment supporting internally to look at what we're doing, as I think some of the board already know, to actually support looking at making sure we are as slick as we can be internally, as well as obviously looking from a wider system perspective. So yes, I think we would all share the frustrations, Naomi, but there's definitely work going on to look at making sure we are at least as productive as we can be with the resources we've got, and at the same time flagging up regionally this is a national problem as well, around the gaps and the shortfall.
I think it's a fair comment, Naomi. I think, you know, it is what unfortunately we're kind of known for, like a lot of trusts providing mental health services. I think what might be useful, what we could do is, we haven't been able to solve the whole massive breadth of child and adolescent mental health, but our sort of biggest weights have been in children's autism and ADHD assessments, and we have made some significant inroads in that. And what we'll do is we'll bring an update report around where that activity is, what we've done, and that itself won't resolve the whole sort of child and adolescent mental health, but it will demonstrate improvement in the most severe area, against a backdrop of a 100% increase in referrals as well, so that perhaps we can see what that narrative looks like. So I think it's a good prompt, Naomi, that we can actually see what we're doing in that area around our most challenging bit of CAMHS.
Thank you.
Yeah, Julian, I think the board would very much welcome an update. So if we can schedule it in summer, that would be good. Because I think Naomi makes a very good point, isn't it? That some of these problems, you know, you do need to have some innovation and some real, you know, determination to solve the problem. Not saying we haven't, but you know, it's just because they're difficult doesn't mean they don't have a solution. And we try all possible options. And I think the board needs to be very visible, have good visibility on this, because it's such a visible issue for our patients. Aileen, did you have your hand up, or have I?
I did, but I must be being a bit slow today because everybody keeps on asking the questions that I was going to ask. So I'm fine, thank you. I just did make the point in the chat about it could be useful to do the you said we did, both internally and externally from the use of the tool, because that could well encourage services that are reluctant, or, you know, to see the benefits that services have actually made themselves. So that's the only other minor little point I would add. Thanks, Martin.
Okay, thank you. When you put your hand up, I'll ask you first, even if you're the last one to put it up. Okay, well, thanks so much, Debbie, for that. Good discussion. Can we move on to the 6-month safe staffing report? And this is a sort of a summary of what's already been reviewed in committee every month. Is that right? And could you just bring out the key things? The paper is, it's slightly difficult to read because it's a lot of detail. I wonder if you just bring out the key things about, you know, where we are in safe staffing rather than all the detail of the processes.
Yeah, sorry, Martin. I tried to make the front sort of couple of pages of exec summary, pulling it all together for you this time.
It might be me, but if you can bring out the key.
So that it was hopefully a bit clearer for people. So if that exec summary isn't, please do feed back to me, because I shall try again next time and to see if I can get it any clearer. So yeah, this is our 6-monthly report. No one will be surprised to know that basically it was showing that we had significant challenges, particularly in terms of registered nursing. And that challenge is particularly seen in our mental health wards. So we've made some good inroads with our physical health wards. We've had some good recruitment from overseas staff, which is mainly into our physical health wards. It is proving much more challenging to secure international nurses for our mental health wards, which I'm not surprised about. Mental health is as a specialty is not in all countries in the same way it is over here, whereas acute medicine is. So that is no surprise, really. In summary, when looking at everything, we had pretty much the right number of staff across Prospect Park Hospital, although they're not always starting on the right ward, and we do have to move people around. And we do rely, as everybody on the board is aware, on temporary staffing quite heavily to achieve that. But as a result, it was safe. I never say it's optimal, because we would really want to have our own staff. The good thing with Prospect Park and temporary staffing is the vast majority of those staff do actually know us really well. So a lot of them work very regularly for us, and a number of them are also our own staff, both who work in the hospital normally and some that work within the community and other services. The area that looks from the tools to maybe need a bit of a review and be slightly under establishment is our physical health wards in the west. So Donington, Highclere, Wokingham and Oakwood. And there's a bit of work going on at the moment looking at that, just to make sure. I think the complexity and difference we're seeing in the patients may mean that we need to review that. The east of the county is all looking fine. So that's kind of it that's it in a summary, Martin.
Yeah, that's fine, Deb. Thanks so much indeed for that. Any questions from colleagues? Sally.
You're on mute, Sally.
You're on mute, Sally.
Debbie, am I right in thinking, looking at this, that our sickness rates are very high, particularly in the east? I mean, about 8%. And if you think the national average is 4.5%, 8% is really high, isn't it, in terms of, you know, what's going on there? And I wondered whether, you know, we'd sort of had a bit of a deep dive around that.
Yeah, so staffing across all of our wards, and not unusual, because if you look at wards across the country, wards tend to have higher sickness absent rates than community services generally. So across, in actual fact, all of our wards, I think there were only a couple of times on a couple of wards that we were below 8%. 8% is our average. What we have seen and in this last 6 months is, so the main reasons for people going off sick are colds, coughs, diarrhea and vomiting, COVID related illnesses. They are the most common frequent reasons for people going off, and tend to spread on wards much quicker, where we tend to have staff congregating in staff rooms and that sort of thing. The absence that causes the most days off, although fewer staff but more days, is stress anxiety at the moment. So yes, we do have the detail of what that is. We have had a lot of staff off with say colds, coughs,
Yes.
COVID, not necessarily caught from the wards, but they, you know, ward staff don't have the ability to work from home in the same way as, say, a community mental health practitioner may be able to carry on working and do their calls from home, etc. So there's a lower threshold, if you like, for being off sick, and there is a low threshold for being off sick on the wards at the moment, because we don't want to be spreading any viruses or infections around the patients or other staff on the ward. So so that will account for some of it.
Yeah, we've obviously looked at it. I still feel, well, that 8%, even into comparable, you know, if we were to benchmark, that's still quite high. But you know, it's obviously been looked at, and you did, hopefully, you know, we're monitoring it, and we'll just have to see how it goes over the winter. Thank you.
Okay, Naomi.
Thanks, Debbie. I just want to link this to a conversation that we had at FIP regarding retention. Certainly Sally, Mark, and, well, several others actually, Debbie and others, and Paul will recall that we had a conversation with Jane about staff retention. And in the course of that conversation, it was a very rich conversation, but in the course of that conversation, Jane gave us some insights into the process that we deliver for job advertising. And currently all our jobs that are advertised, so all our vacancies are advertised on the NHS Jobs Board, which means that all our individuals internally, if they want to apply for a job internally, have to go via the Jobs Board, which means completing fairly lengthy form and also competing with individuals externally. So, which actually for me came as quite a surprise. So through the discussion, and this is a work in progress that Jane has on her agenda, to look into developing an internal jobs board, which would make life an awful lot easier, and rightly so, for our nursing staff and others internally to compete for jobs internally. It's you know, so she's driving towards a new policy, which I think is absolutely the way to go. It would be standard practice in everywhere else that I've worked. So I just wanted to bring that to the attention of the board as something hugely positive that is going on. And we've asked Jane to come back to the FIP to report on progress on that in short order.
Yeah, thanks, Naomi. Yeah, retention's really, really key. And one of the other things we've started doing is a kind of internal rotation. So not everybody wants to commit to working forever on the inpatient wards, for example, but rather than having to leave and find somewhere else. So we have got some staff. I think we've got 4 staff who've started this recently, which will be an internal programme, which means they spend some time on the wards and some time in the community. So we're looking to see how that goes as a pilot as well, to see if we broaden that out a little bit.
Thanks so much. Anything else on this? Okay, well, thanks so much, Debbie. We better move on. 6.4, Research and Development Annual Report. Minu, this seems to be going well, but I'll hand over to you.
Thank you, Martin. Good morning, everyone. I thought I'd make colleagues first aware that we have Kate Penhaligon observing today. Kate is our head of research, who has joined us in February of this year, while Katie Warner is on secondment. So I don't expect Kate or myself to present the whole report, but I'll just give a brief overview of what we're trying to tell the board, or what are we bringing to the board in this report. So we're sort of briefly celebrating the achievements of the R&D department. You'll see it in the summary of, you know, where we stand against other organizations in the country. But importantly, we are providing the assurance that we have good governance processes so that our research participants are safe when they take part in research. We are highlighting some of our good quality research projects, especially if you sort of look at the COVID times, when we participated in a number of sort of large trials involving multiple other organizations. And our research portfolio is a little bit tilted towards mental health, and I don't apologize for that at all. I think mental health needs every piece of research it can get. We are also providing assurance about a financial balance here. we have to remember we have been increasing our research income year on year, and just by the activity and the amount of work we do and research we attract, and that income covers virtually all of our expenditure of the research department, except for the salary of the head of research. So that's our financial model in research. But apart from the assurance, we also want to talk about a couple of our aspirations. We've got a research strategy where we have started collaborating with other institutions, mental health trusts in the NHS, universities, and we want to participate in high quality multi-center research trials, even if we can't have phase 1 and phase 2 research on our own sites. We would like to participate with others in phase 3 and 4 research. And we also aspire to improving the access and the equity of our research. And there's a mention there about going for the opt-out model rather than the opt-in model of research. And I think these sort of approaches go a long way in ensuring that some of our patients who are less likely to be asking for research will get an opportunity to be aware of the research projects. So that's the aspiration bit. And finally, just a little bit of awareness that we are aware that our participant numbers for next year may not be as high as we've always had. And that is for a number of reasons, especially if we want to change our strategy slightly from just high volume research, which might be questioned as to a strategy of actually high quality research, then sometimes the numbers game is not entirely well played. So that is sort of my very brief overview, but happy to take any questions or any comments from colleagues.
Many thank you, and welcome to Kate. Sally.
Minu, you've been very generous with your time, and I've had an opportunity to meet with you and Kate and discuss the research across the trust, and it's great to see that actually we're punching above our weight actually in terms of research. And at the time I asked you thousands of questions, so but indulge me. Given our focus on practitioner research, I wondered whether we'd how we are in terms of strengthening the link between research and learning and development, to give people the opportunity through learning and development monies to participate in practitioner research. And is there any development around that? Because we've been very successful recently, haven't we? We've had a few awards around that.
Absolutely. And I think, and this is where Kate has been doing a lot of work in engaging our various services, our frontline clinicians and practitioners in understanding the research opportunities available to them and supporting them through that. I wouldn't be able to comment on whether learning and development monies can be used for research. I think that is an area which is too complicated. But what we are also trying to do is, apart from embedding our clinicians in the services and linking them up to the research team. So rather than only having a central corporate team, which is really very tiny, to be honest, our research team, we have staff embedded in various clinical services. And that's what we've been doing for the last 2 or 3 years, with some research time and then supported by our central team. And that model has worked well in attracting research. So that's one approach. But we are also, and some of the work that Kate has started is working with our QI team, our sort of audit team, and trying to bring all of these together, because research in isolation is in isolation. Research as part of quality improvement, learning from audit, and the various clinical services is what we are trying to do internally. Of course, externally, we have the sort of big aims of collaborating with other organizations, etc. So yes, Sally, absolutely sensible suggestion and question, and we are working on all of those things at pace as much as we can do.
Thank you.
Okay, anything else? No? Okay, well, thank you very much, Minu, Kate, and we'll see Kate at next meetings, I expect. So welcome. Okay, 6.5, quality and safety in inpatient services, Debbie.
Thank you, Martin. Yeah, this report is here for the full board because I thought it was really important on the back of the Panorama programme, which I'm sure most, if not all of you have seen, and the shocking coverage there. And to be honest with you, you know, back when you look back to Francis in 2013 and many other reports since then, they all fundamentally are around cultures and the fact that poor and closed cultures have been able to develop. And as a consequence, we see some of these appalling things happen. So I was really keen that we brought something to the full board about this on this occasion. I'm hoping it's self-explanatory. What I have done is, so Claire Murdoch did write to all mental health trusts after the Panorama programme, highlighting what I've just said really about poor and closed cultures. I think we'd be really naive to say that they could never happen here or anywhere else. I think closed cultures can happen anywhere. I think it takes hard work and perseverance to ensure that you maintain an open and positive culture. And as you will all know, we've done quite a lot of work around cultures over the last few years, looking at our HR processes, looking at how we support staff. Some of that we've heard here today, but it is something we need to be mindful of at all times. So I have attached a report which a number of people have helped me with, including Minu, and it really outlines the things that we think we've already got in place to support continuing to have an open culture, and some of the things that services are saying they'd quite like to do differently or more of, just to continue on our improvement journey around culture. And I'm really happy to take any questions.
Debbie, thank you. Mark.
Yeah, Debbie, thanks ever so much. It was a good comprehensive response to what came out in that Panorama programme. The thought occurred to me, as you said yourself, it's to do with the culture that exists within those areas. And if we do a board to ward visit, I do sometimes feel that whilst it's not the red carpet treatment, they are aware that we're arriving. And the benefit in my mind of the 15 steps visit is that they are unannounced, they are unexpected, and very often we're kept at the door of the ward until they verify that we're allowed access. And your report made the point of conducting some of these at night time and in the evening at times when they wouldn't normally expect it. Whether or not we as NEDs could participate in a number of 15 steps visits over the coming weeks and months, targeted specifically at those inpatient wards in the evening when they wouldn't normally be expected, so that we can spend time talking to the staff and to some of the patients and assuring ourselves of what is happening in those wards.
Really happy for you to accompany Mark. So I visited Prospect Park with Tamina. We were there from 10:30 till 12:30, as in midnight, not morning. Couple of weeks ago, it was planned already in actual fact, and we went to every single ward and Campion and Oakwood and CRHT. I was at Wokingham last Thursday night, just dropping in. These are always unplanned, and I'm going to West Berks in a couple of weeks' time, and I do visit night visits, but I'm really happy for anybody to accompany me on them. That's no problem at all. What I would say is the staff were all very willing to chat to me at Prospect, including the temporary staff and students, a couple of new starters. And so were the patients that were awake. So really happy for you to, if you'd like to join me on one of those, that's absolutely fine, because I do think it's really important for us to do that out of hours.
Yeah. Let me know the date of your West Berkshire. I'll join you in a couple of weeks.
Okay.
Thank you. Thank you.
Thank you very much. Naomi.
Yeah, thanks, Debbie. It just occurred to me that in your very comprehensive list of activities and pursuits and approaches that the trust is taking to address this particular issue, I didn't see it, but I might have missed it. The work that we've done on casework. So this is the HR, the change in policy to disciplinaries. It just struck me that I think that is moving the dial, and is another one to sort of add, because it speaks very powerfully to a just culture and empathetic leadership.
Yes, agree. I thought I'd put that in, Naomi, so I will double check, because it
I
does.
might have missed it, in all honesty. I've just been repeating it, Debbie, but I couldn't see it there, but whatever.
Yeah, when I tried to pull this together, there's so much that we could put in, and I thought I'd put that in, so I will double check and add that in. Thank you.
Great, Debbie, thank you. And certainly my only comment is, addition to the others, is just important of speaking up. You know, the culture where genuinely everyone is able to speak up, and that we as a board support that absolutely, which I know we do, but you know, we make sure it's really embedded. And the only other slight observation, which I don't think is in your paper, from my own experience elsewhere, is that if you have a very complex organisation, structurally complex, it's quite easy for a little bit to be hidden or not to be as visible. So even though the culture might, right, you have a little team here who's doing a good job, you know, and they're not really very visible, and sometimes that can cause a problem. So sort of complexity in organisations seems to me not a good thing in this context. But I think some great stuff going on, and I think the assurance we get really is the very high speak up confident staff have, but it's something we have to keep working on, isn't it? It's not going to so thank you very much indeed for that, Debbie. If there's no more questions on that, if I can get the agenda back up. Executive report, Julian, we do normally just take questions, don't we, on this?
Yeah, there's quite a bit in there, Martin, so I will leave it to you. As you can see, we did take the stakeholder survey in private last time, because the remarks were attributed to people, and obviously we just anonymised them now because people didn't know they were going to be put in the public domain. So it hasn't changed, other than that actually obviously the comments are anonymised, although about half of them we had names against them because people wanted to know who had made them. So it's just to put it in the public domain. I think, as I said last time, you know, what your patients think about you, you know, what your people think about you, and what your partners think about you are, you know, the cornerstone of kind of your kind of judgment, I guess, really. And this is one element of that.
Yeah, that's fine. I think it's very good. Any questions for Julian? Aileen?
Yeah, I got in. It wasn't really for Julian, it's for Debbie, because it was about the uptake on the flu and the COVID jabs. It looks quite low. I was quite surprised to see it, given I would have expected us to have the rollover of people still being very concerned about COVID and reports of it coming back up, and we've got the bus going round, and you know, we're making it as easy as possible for people to actually have those. And you know, what's your feeling about the level of and what are we going to do to try and get them up further?
So yeah, it is really low, Aileen. Aileen, and we're seeing this across nationally at the moment. Really poor uptake. And yeah, we do want to get it up. I'm really disappointed in how low it is. It's lower than we've seen it for a number of years. I think there's a combination of things. I think we've got vaccine fatigue, if you like, where we keep every couple of months telling people there's another booster or there's another, you know, flu jab or whatever. And so people are a bit fed up with it, I think, to be honest with you. I think that's driving a lot of it. I do think that's driving a lot of it, to be honest with you. I think the other thing we don't have the ability of this year, we didn't have last year either, but people were more worried last year, I think, is the ability to have lots of people in one place, or people, you know, we've got a lot of people working at home still, so they're not in a site where we can just nip round, which is what we normally do, nip round with a few vaccines and, you know, fortuitously give people a jab while they're there. So I think we've got a combination of things going on. But I do think vaccine fatigue is driving a lot of it, and along with media, you know, COVID's not as bad now. There's not as many people that are being hospitalised because of it. We've had 2 years of really, really low flu because everyone's been social distancing and all that sort of thing. So they haven't experienced bad waves of flu for a couple of years. So we are, keeping on the messaging. We are doing lots of ad hoc. We're trying to make it as easy as possible for people. But yeah, I am worried it's so low.
Yeah, because this is going to, with the difficulties of staff numbers and things like that, it's just going to be, extra problem. And I know you know that, but it's just kind of worth saying it out loud, isn't it?
No, it really is. And, it's a big part of business continuity planning, trying to give people as much in their armoury as possible to remain as well as possible. But what I do know is we're not alone. When I was talking to all of the acute trusts in both Band, Frimley and the Mental Health Trust, they are all at about the same sort of rate at the moment, and nationally that is the uptake nationally is really low as well.
Gosh. Okay. All right then. Thank you.
We won't worry. Anyway, I'm sure all the boards had both theirs, so it's we tick the box. Okay. All right. If there's nothing else, can we move on to the finance report, item 8? Paul.
Thank you, Mike. If I just plug just some of the main bits from the report. So obviously it looks like a relatively good financial position. We've finished the first 2 quarters with £100,000 surplus, which is 700 better than we planned. You'll probably see from the run rate charts in the report this month, we've got spikes in pay costs and income, and that's just reflecting the settlement of the current pay award going through. So backdated pay paid in September with funding coming through from the ICBs. Probably worth just noting that we managed to negotiate a more favourable position on pay award funding than we anticipated this year. So we've flagged before that mental health and community providers, because of the proportion of pay spend that they have compared to average providers, when the funding flows through tariff, we normally disadvantaged and see a pressure. So it was encouraging to see that Bob recognised that pressure and push some additional funding our way. I don't think it sets a precedent for future years, but it was good to see in this instance that it was recognised, and we'll pick it up as we go into conversations around planning for next year. Also encouraging to see that substantive workforce increased this month. September traditionally a month where we do see an increase with some of the trainees moving into new positions, particularly in IAPT services. But obviously that belies the fact that we're still behind our workforce plan in terms of investments into services and the core services. Still seeing pressures across our mental health services, which most obviously is manifested in terms of the number of out there replacements we've got, which are increasing, opposed to the plan which indicated we wanted to decrease during the year. We've extended some of our block booking arrangements for the remainder of this year, given the actual likelihood of those numbers coming down, which at least gives us guaranteed access to capacity and certainty over price for the remainder of the year. Obviously, two quarters into the year, we've just forecast for the year end, and we've taken that detailed forecast through our executive committee, and we discussed it at length in Finance and Performance Committee a couple of weeks ago. If we look at some capacity costs which we've got coming online, particularly around CAMS, which I know we've mentioned previously in this meeting, and workforce predictions, what we think placement numbers are going to do, and inflationary pressures through to the end of the year, we've put a forecast range of between a 1.5 million deficit and a 2 million surplus at this stage, so about a 1% range of turnover. Given that we've put a forecast into the centre in line with our original plan for the end of the year, which is a 900,000 deficit. And obviously we're going to keep this under review monthly now until the end of the year. And if we need to make changes, we'll bring those to the board. No concerns with cash, still strong cash position but expect that will reduce during the course of the year as we increase capital expenditure, and capital expenditure, not unlike other years, we're behind plan at this stage, but we expect to complete on certainly our 3 major estates projects before the end of this year, being new NSK accommodation in Newbury, our head office move in Bracknell, and new accommodation we're bringing online in Windsor. Probably the only other thing to note, which would be remiss given some of the headlines that are coming through at the moment, in terms of the system finances, both Frimley and Bob ICSs, despite still forecasting break even, are in deficit positions at the moment and well behind plan. It's safe to say that finances are going to escalate up the system and national agenda over the coming months. We've got meetings planned with Bob, Bob themselves as a system have got meetings planned with regional and national teams in the coming weeks to discuss what the financial forecast is looking like and what systems can do to try and mitigate the pressures towards the end of the financial year. But it's a difficult position to be in if we're already in deficit, expecting that systems are going to fully recover financial positions over the winter period, which is traditionally a challenging period, obviously, for the NHS. But happy to close there and take any questions, Martin.
Thank you very much. Any questions for Paul? Paul, oh, sorry, Sally.
What I was going to say, Paul, is I'm really delighted to see the Community Enhanced Rehabilitation Service business case has been approved, because I think that sort of, particularly with the step down, I think if you can get step down provision, that can really help in terms of bed flow in at Prospect Park. And I just wanted to ask if we were going to go out to tender with the social care sector, because they can often provide a lot of that, can't they? We might have input into the medical bit or the nursing bit, but they can actually support staff, support service users who are stepping down.
Yeah, I mean, we're looking at we are looking at some non-recurrent investments into voluntary sector, and with this one, I know they're trying to escalate plans in terms of getting the recruitment in place. It's fair to say that obviously some of the pressures that we are seeing on the inpatient beds is because of the support required in the community teams to try and pull some of those patients out. Yes.
Yes. Yeah, and social care can help in that sense.
Paul, I've just got one sort of philosophical comment, really. I mean, clearly things look well under control, which is great. Thank you. If one thinks of the next sort of few years, one imagines that things might look, very tough for the service generally. And I'm not asking for a response, but I just think we need to be thinking quite creatively about how we might respond to some of these financial challenges that perhaps to date we've managed to navigate rather well. Rather than just thinking about a little bit of cost improvement here, a little bit of cost improvement there. Are there any options that might at the moment be inappropriate, but which might become the best of a worst, a bad set going forward if things did get bad? So we have some clarity about, what we might do if the worst happens, sort of thing. I don't come back to me now unless you want to tell me I'm being stupid, but I just sort of feel we need to be a bit more open-minded. Not that I think there's some easy low-hanging fruit there we can just pick in future years, but I'm just not. I think we've got to be prepared for some quite difficult times. Do you think?
I think that's absolutely right. I mean, I think we've got we know we're going into the next financial year with the NHS as a whole challenge. So inflation is still higher than what the original funding settlement was. Although we expect NHS funding not to be impacted by budget next week, we've got no guarantees on that, and certainly no guarantees on any increased funding going through. We've still got nationally the pressure of the higher pay award flowing through, and obviously we don't know what pay award's going to be next year in terms of whether it's going to be higher than what was originally anticipated in the funding settlement. So I think it's not, you know, it's not remiss at all to say that we've got to be planning for harder times ahead. I think that we're going to bring something next month to board around what output looks for kind of first early views for next year. And like I say, I think it's also prudent, given what you said, to be thinking about, you know, we haven't got a lot of ability on low hanging fruit. We're not probably going to be able to salami slice our way out of this. So there may be some you know, more strategic things that we need to get into. It could be that there's some opportunities across the system that we're looking at, which we've started this year, certainly with Bob, to look at system-wide efficiencies, but they're safe to say they're probably not delivered as expected this year, and there's probably more work to do in preparation for next year and the years to come.
Yeah, the only silver lining, just before I invite Naomi, is that when you've got a bit of a crisis, it does stimulate innovation, and you know, so it might have a silver lining to it, even if we'd rather it wasn't. Naomi.
Yeah, thanks, Martin. And you've just sparked a thought, which is something that we might just want to think about going forward, Paul. This is really is food for thought, and I know it's got sort of big holes in it, so forgive me. But you know, in most organisations, what they tend to do is look at their 3 to 5 year strategy, and then they marry up the finances to that. So what they attempt to do is to say, look, if these are our strategic objectives over the next 3 to 5 years, you know, and then you do a sort of low, medium, high case in terms of the financial frame that would be required in order to fund that strategy. That would be typically what, you know, most organisations do. And I 100% appreciate why it is we in the NHS kind of resist that, because, you know, well, just the way in which the body is funded makes that incredibly difficult, but not impossible. So, you know, it is within our gift to kind of say, look, given this strategic objectives, given this level of ambition, given this level of uncertainty and risk, this could be the financial frame that would be optimal. And then you work with the reality that sort of overlies that in terms of your funding proposition going forward and all the stuff that we're not actually in control of. So I just think it'd be worthy of thought, because we can do it, and so why wouldn't we?
Yeah. Okay. Thank you, Naomi. Anything else? In which case, thank you, Paul, for that. We can move on to performance report. Back again.
Yeah, so again, like I say, take it as just to highlight a couple of lines from the performance report. So in terms of breakthrough objectives, we look at falls, slight increase this month, but I think always good to bear in mind we do benchmark very, very well nationally. So this is a real stretch target for the organisation. We've got a number of wards in month that have recorded no falls, and just to pick Oakwood as an example, historically a relatively high contributor of falls, and in kind of that mould of quality improvement have actually now taken on the view of actually reducing their local target, given they've been below their initial target for 8 months now. We've now agreed and procured a single fall solution for the organisation as well. We had 2 in operation previously, so again that's a step forward, and hopefully we should see the benefit of that in coming months. If we look at self-harm, again 69 incidents, but probably just reminding the board that a number of these incidents are related to a relatively small number of patients. So 4 patients this month accounting for 44 of those incidents, 9 patients accounting for the remaining 25, and teams are obviously still heavily focused on one-to-one work with these patients and how they manage their self-harm incidents. Was going to mention I Want Great Care, but obviously Debbie's mentioned that those metrics positive and heading in the right direction. And then just I guess there's probably 4 or 5 metrics within the report which give an indication of the pressures on the organisation at the moment. So staff turnover remains high at 17%. We've discussed that. We know NHS workforce issues are well documented. And Jane and the HR team did a 2-day rapid improvement event recently focused on retention, which has generated a number of actions which they're going to implement. And obviously, Naomi indicated we discussed this quite at length in FIP, and will continue to do so. Mentioned out there replacements. Obviously, target for the quarter has been exceeded, which is probably unsurprising given the pressures on mental health inpatient beds. And if you look at delayed transfers of care and occupancy levels on mental health and community beds, we're starting to see high levels of delayed transfers of care out of those wards, and occupancy levels now in excess of target as well. So indicators of obviously the system hotting up and pressure on services at the moment. But happy to hold it there and take any questions.
Okay, I think it's a very clear report. Any questions? No? Okay. Thank you very much, Paul, for that. Where are we? Finance FIP. Naomi, did you have any comments to make?
Just very briefly, Martin, because so much of what we of the agenda for FIP 2 weeks ago has already been covered. So by exception, the FIP had asked for a bit more detailed insight into the growth of management and administrative whole-time equivalents over the last 18-month period. And a reasonably detailed report was provided. It showed that the growth from a baseline had increased by about 60 individuals over that 18-month period, which at first blush might seem quite a lot. So what the committee wanted to better understand is a couple of things. One is the sort of process through which the decision-making process through which those recruitments, those additional recruitments have taken place. Took good assurance that there is a really robust process of decision-making in place for that to happen. The other was, is asking the question: do these individuals marry to areas of requirement at the front end? So do they marry to specific activity sets? And the answer is yes. So, for example, additional admin staff were recruited to support the HR agenda and indeed the digital agenda. So that was good. And then last but not least, the committee asked to keep a watchful eye on this, recognising that the optics of this could be poor at the sharp end when people at the at the clinical end of the scale are struggling to we're struggling to recruit there, and yet apparently not in the admin part of the organisation. So some really valuable insights which FIP will continue to pay attention to. And then just another couple of things, Martin, which we've touched on already, that we took another report on the HR casework studies. So this is the disciplinary policy that we've been working hard on to adjust to a more empathetic approach. And the good news is that this is an arrangement that continues to gather momentum in a very powerful way. So the number of formal disciplinaries continues to drop. We're seeing some really good indicia in terms of how it stacks up in terms of our BAME community and the equity of the process across the trust when you look at it through the ED&I lens. So we've said to Jane, look, this is going incredibly well. So only in the event that it starts to go off track would we want to see it again. And then, as I've already mentioned, in terms of staff retention, Jane gave us some really deep insights into a rapid improvement event that had taken place on staff retention, given that our metrics, our retention percentage is going in the wrong direction. So continued really heavy lifting and hard work to pay attention to retention. But the aha moment came around the fact that we advertise everything externally for all our vacancies, and it was felt quite strongly that we need to manage that by offering up a much easier way for our own staff to move around the organisation so that we can keep them. So with that, I'll pause and take any questions.
Thank you, Naomi. Any questions? No. Thanks so much, Naomi. Rajiv, Audit Committee. I think probably just take questions unless you've got any particular things.
I just mentioned 3 quick things. It's on page 7.1 of the pack. So the first is we did have a presentation from the EU PD pathway. Minu and I agreed this would be the last one that would come to Audit Committee because it's more of a business as usual as a project anymore and now ongoing. The second is we did have our usual representations from anti-crime, TIAA, the internal auditors, external auditors, and I continue to be very impressed with the way that they represent what's happening in our organisation and the feedback they give me. And the final thing is if we look at the volume and the size of the amounts that we see in the single tender waiver report and the audit differences, it does appear to be higher than you would like to see. And so one of the things I would normally look at is when you see values that are common and high, is are these errors, are these isolated control weaknesses, or are they more systemic? And I think we have enough assurance from all the various parties that these are not systemic issues, that they are known and they are in control.
Very good. Thank you for that. Very, very clear minutes too. Any questions? In which case, thank you very much, Rajiv. So we get back to the agenda. Trust seal, Paul.
Yeah, I'm happy to take any questions. I think summary outlines the instances where it's been used, which is the obviously taking on the lease of the new headquarters in Bracknell and Dedworth Clinic replacement, Fair Acres in Windsor.
Any questions? No. Okay. Councillor Governor's update. Just to say that I think the Governor's very much welcomed the chance to contribute early in the strategy development process. I think that was rather than we tended to come in the past rather late with a sort of almost finished strategy, whereas now we've invited them to come in earlier in the process. I think that's been welcomed. The Governor's reviewed the revisions to the Trust Constitution, which seemed to be a helpful meeting. And I think the Governors really do continue to welcome the joint NEDS Governors meetings and the chance to interact with NEDS in an informal way. So that's good news. Item 10, any other business from anyone? The date of the next public board meeting is the 13th of December. I'd normally just close the meeting now, but as we have some observers, Juliet, Tom and Stephen, just a few minutes if they have any questions about